Can you please introduce yourself?
So my name is Chris Wincup. I'm a consultant rheumatologist working at King's College Hospital in South London. And my main area of interest is in the care of people with lupus, which is a chronic autoimmune condition that affects about 1 in 1,000 people in the UK.
Why did you choose, rheumatology, immunology, and lupus?
So I always was interested in musculoskeletal health, dating back to when I was before I started medical school, because I enjoyed playing sports. And I initially thought that my interests would take me more into a surgical field. But actually, what I found was that in combination with my love for immunology is what really drew me towards rheumatology as a specialty. And I think I was lucky to have many great mentors when I was at university. And many people said that rheumatology is an area where very little is currently known. And if you can learn a little bit about rheumatology, it's almost like turning on a small light bulb in a very darkened room. And I thought that was a really interesting way of considering it. And my passion for immunology has really continued. And that's kind of what really drew me to rheumatology and in particular into looking after people with lupus.
Can you explain what lupus is and what inspired you to focus your research on this disease?
So lupus is a chronic systemic autoimmune condition that is characterized by antibody formation, or at least that's what the textbooks will tell you. So in simple terms, we don't know what causes lupus, but we know that this is an autoimmune condition where the body's immune system that would otherwise protect you from infection for some reason gets confused and starts attacking the body's otherwise healthy tissue, and depending on what part of the body gets involved then causes the symptoms. So for example, if the immune system starts attacking the skin, then people develop a rash. If it starts attacking the joints, people will develop joint pain and arthritis. And if it starts attacking the kidneys, then we can see damage to the kidneys, and we often pick that up on urine and blood tests. Now, the exact cause of lupus is not well known, but we do know that it's an immunological condition and that there are certain people who are affected more than others. So this is a very discriminatory disease. We know that 9 in every 10 patients with lupus is female, and also more aggressive forms of the disease tend to affect younger patients. The disease can present in a number of different ways, which means that it can be very difficult to make the diagnosis. And that's usually because it takes a bit of time for the clinician who's seeing the patient to put the various pieces together to make the diagnosis. We've learned a lot about the disease in the last 10 to 20 years, and I think this is one of the areas that really inspired me to take up research in the field of lupus, because we know a lot more about the human immune system and the abnormalities that occur in lupus. And one of the things that I'm really passionate about is now learning about how the immune system can tell us about what treatments work best for people with lupus so that people get the right treatment at the right time. And this is something that I'm really passionate about, and I hope we'll learn an awful lot more in the future to make sure patients are getting much, much better treatment and living much better lives with the condition.
What are some of the most significant challenges you face as a clinician when diagnosing and treating lupus patients, especially given the complexity of its symptoms?
So I think there are a few major challenges for clinicians looking after people with lupus. Number one is in terms of predicting what might happen in the future. So often we have to speak in very, very general terms. For example, we know that half of people with lupus are likely to develop problems relating to their kidneys. And so when I talk to patients when they're newly diagnosed, the question is often, well, am I in the 50% that's at risk of this happening? And unfortunately, we don't have any particularly good predictive measures. And I think this is incredibly frustrating for patients because we often say you have a chronic unpredictable illness and find it very difficult to give them any facts at the start to reassure them or to warn them or caution them about what the next few months and years may tell them. So I think this is one of the major challenges that we have as clinicians in terms of telling our patients where the risks are and what the future personally looks like for them. Similarly, we know that we do start to develop a number of drugs that work for patients with lupus that can be very effective. But at the moment, not every drug works for every patient. And we don't have any good markers before we start the treatment as to whether that person will, number one, feel better with the treatment, and number two, they won't develop any side effects to the treatment. So I think one of the areas that I'm particularly interested in at the moment is seeing whether we can find out predictors that we can give us the confidence that when we see patients and start them on a new medicine, that we can say that we think this is highly likely to work for you, and you're unlikely to get side effects with this medicine.
And actually, an additional question on this one, what do you think, and maybe what have you found, what is there in the scientific literature, the research at the moment, what are the potential predictive factors, things that could help clinicians make the best decision on what treatment to start first? So we usually hear about pharmacogenetics potentially, but I know it's like usually multifactorial. And so pharmacogenetics, the fact that your genes, certain mutation in genes will predict what medication works. What are your thoughts on this?
Well, I think we need to learn from other specialties. So trial and error is okay when you don't have any other options. And currently in the treatment of lupus, we have some suggestions of treatments that we think will work for particular manifestations. So for example, we know some drugs will work better for people with joint involvement. Some people will work better for patients who have kidney involvement, but they're never 100%. I think one of the things that we really need to do is look at our colleagues in oncology, where they have a number of different targets for patients, and they have a much better way of stratifying them based on immune signatures of their underlying disease. So, for example, we know that lupus is driven by a number of antibodies, and therefore targeting antibody-producing cells called B cells is a good target, but not everyone's lupus may be triggered by B cells, and therefore targeting that is not going to make them better. We also know there's parts of the immune system where we see inflammation, so chemicals called interferons can be produced, and we now have a drug that targets interferon. So we need to have a much better understanding of what the driver of an individual person's disease is to tailor the treatment so that we're giving them a medicine that directly targets the thing that's making that person unwell. And I think that's the direction we need to travel in to make sure patients get the right treatment.
It's fascinating. I remember, that's another one I will add because I'm just curious about it. I talked to a professor of, rheumatology from Harvard, actually, and even told me, like, lupus at the moment, we're putting a lot of different patients into lupus.
Yeah.
But maybe it's actually a lot of different small conditions.
Yeah.
I don't know. What are your thoughts about this?
Yeah, so I think that there's a lot of debate in the field about what lupus actually is, and many people are fairly comfortable with thinking of this as a spectrum of different symptoms. Now, the question is it a spectrum of different diseases that we all call lupus? And at the moment, we don't have the information available for that. We certainly know that people can be in very distinct groups, that their future looks very differently, that their response to treatment can be very different. But at the moment, we can't divide people up by simply saying you have arthritis due to your lupus, and therefore this is the type of lupus you have, because sometimes those people then develop lupus in their kidneys. So is that a different type of lupus? Is it part of the same thing? Or is it that it's a very separate entity that just involves the joints and the kidneys? And so I think that we need to do a lot more work to better define patients. And I think ultimately the importance here is not just in terms of getting a clear diagnosis or pathway for us as doctors, but also to give patients that reassurance. So, for example, in the spectrum of lupus, there are certain patients who will have one nasty, severe flare of the disease when they're first diagnosed, and then the disease can become much more settled in the future. So is that a different type of the disease or a different entity entirely from the lupus that we classically see in clinics, which is episodes of flares between periods of remission? And so I think we do need to learn a lot more about this, and we can't simply base this just on patient symptoms or the traditional blood tests that we look at, but we do need to go in a lot more detail within the immune system to see if this can allow us to look in more detail at higher fidelity in these different groups to see if there is differences across the spectrum that we are currently calling lupus.
Can you discuss a research achievement in lupus that you're particularly proud of, and what impact it has had on the treatment or management of the disease, or that it could have, because sometimes in medicine it takes years, obviously?
So in terms of my own personal research, one of the things that I'm most proud of was a small piece of work that I was doing during my time at UCL that wasn't actually part of my main PhD project, but was a project that we did on the side, where we looked at anti-drug antibodies, and the drug in question was rituximab. So the story for rituximab is sadly quite a tragic one in many cases. It was used in 2 large trials in lupus, both of which were unsuccessful. But in the UK, we do have some good open label data and are able to use the drug relatively freely. And we know that it does work in a subgroup of patients. And I think one of the challenges is identifying which patients respond to that drug and who don't. And what we found from our research was that a large number of people with lupus who are treated with rituximab develop anti-rituximab antibodies. And importantly, when we found this out, we realized that in patients who had levels of these anti-drug antibodies in their blood, when we retreated those patients with rituximab, those were the patients who then developed infusion reactions. So if we could monitor those more closely in patients having had treatment, we can potentially identify those at risk of infusion reactions and adverse events of treatment, and then think about giving them an alternative agent. We then also realized in a separate study that these anti-drug antibodies had an impact on the response to treatment. So although patients responded quite well to the treatment if they had the antibodies, the treatment tended to wear off sooner and the patients had a flare of their disease quicker. So this might help to explain why certain patients within clinical trials did not respond to the drug. And I think that the impact that this is having on my own research is we're now looking to identify whether there are particular markers of response to rituximab treatment that may explain which patients will respond to the treatment and which won't. And I think that's important for future clinical studies and potential trials of similar drugs, so that we can perhaps enrich for those patients and see who is more likely to respond to that therapy based on these biomarkers. So I think that's one area of research that was particularly impactful for me and has really prompted me to look into the area in much more detail going forwards.
Yeah, and I don't remember if it was rituximab or another one, but I remember in the kind of research and interviews I did, one was someone who I think she had Crohn's disease or ulcerative colitis. She was put on immunotherapy, biologics, and then she developed a drug-induced lupus that I didn't know about, that I heard.
Yeah.
Is it linked to this, or is it something different?
So it's an interesting area. So drug-induced lupus is something that we do occasionally see in patients on other biologic drugs, particularly anti-TNF drugs, which are used in the treatment of rheumatoid arthritis and ulcerative colitis and other inflammatory conditions affecting the bowel. There is a risk of developing this drug-induced lupus, in which the symptoms can be fairly similar, and there are, again, very, very specific antibodies for this. In many cases, much like systemic lupus or the lupus we're more used to treating, it is something that can take a bit of time to work out and notice. But it's something to consider in all patients who are starting on a biologic therapy or any new drug, really, of which there is a risk of drug-induced lupus, who may present with unusual symptoms that are not typical of side effects of that medicines, such as rashes, joint pains, mouth ulcers, or any other symptoms that cause concern. And there are very simple blood tests for this. So an antihistone antibody test is very classical for a drug-induced lupus. But this is something that I think all clinicians need to consider, particularly those using these anti-TNF therapy drugs.
Yeah. In your opinion, what are the most promising developments in lupus treatment that patients and healthcare providers should be aware of?
So I think that we can be somewhat more optimistic about the future for the treatment of patients with lupus in the future. The area that is causing the most excitement at the moment is relating to what we broadly term as cellular therapies. So that includes things like CAR T-cell therapy and bispecific T-cell engaging therapy, which are, again, therapies that we're borrowing from our colleagues in the hematology world, where the treatments have been shown to be hugely effective for treating a number of blood cancers like lymphoma. And many of the drugs that have been used successfully in the treatment of hematological disease in the past have been used in lupus. But really, the initial results we're seeing from these very small open label studies are astounding. So CAR T-cell therapy in particular has driven an awful lot of excitement. For me, this is particularly interesting because it's targeting B cells, which is what we try to do with rituximab, albeit that rituximab did not work in the clinical trials in lupus. But the results here are particularly exciting because what we're seeing is that patients are achieving significant amounts of remission and control of their disease within as little as 3 months. Now, these are open label studies. These are not studies that have been used in many, many patients, and these are also completely outside of many clinical trials at the moment. So we do have to be cautious to some degree. But what we're seeing is that patients' diseases are brought rapidly under control within about 3 months, and it leads to a complete resolution of of the symptoms and immunological abnormalities that are seen in the disease. Now, from a hematological perspective, there can be some risks with this therapy, but we're seeing in the current data very little of that in the people with lupus and autoimmune conditions being treated with CAR T-cell therapy. And I think the most striking and interesting thing of all is that even when patients' immune systems return to normal, i.e. their B cells return, they don't have a further flare in their symptoms, and many of these patients have gone into full drug-free remission for more than a few years, which is really exciting. And I think we'll all be keeping a very close eye on what the long-term outcome for these patients are, because if we're able to develop a state of long-term drug-free remission, then that will completely change the landscape of how we treat people, not only with lupus, but with many other autoimmune conditions that are characterized by antibody production.
Yeah, I think CAR T cells, we talked about it, and if I'm completely honest, I still don't know or understand, really like how it works. I think it involves, B lymphocytes, like B cells. That's something you mentioned, but like what happens in the body, maybe kind of in simple terms, and as a patient, if I have it, like what does it involve? Like, do I need to take like a drug? For how long? And could you please tell us a bit more about this?
So CAR T-cell therapy is very different from the typical studies that we're used to doing as rheumatologists, in which patients will come up to hospital, typically have an infusion of either a drug or placebo, and then go home the same day after they've had some clinical assessments. CAR T-cell therapy is a lot more intensive and laborious. So the process of CAR T-cell therapy can begin in a number of ways. Now, the most traditional way is what we call an autologous CAR T-cell therapy, in which the patient donates their own T-cells. So in this state, patients will undergo a process called apheresis, in which their blood is taken via a machine. The special immune cells called the T cells are taken out, and they are then stored and shipped to a laboratory, where they are then engineered to attack new targets. So, for example, B cells. And then these are grown in a lab to very, very high numbers, shipped back to the patient, where they are then infused as a treatment. Now, before the patient has the infusion of treatment, two things usually happen. Number one is they have to undergo a treatment with very strong medicine, in which we call the process lymphodepletion, which essentially suppresses the immune system further before these T cells are given. And second of all, the patient usually has to taper down some of the other medicines they're on to make sure that the drug is effective when it's given. The medicine is then reinfused to the patient, and the patient is often kept in hospital for approximately 10 days, where they have very close surveillance to make sure there are no side effects that can occur within the first week or so. And then following discharge from hospital, they have to be relatively close to the hospital within the next month to make sure that they're again safe and not having any adverse effects to the treatment. The key difference is there is also a growing interest in the role of allogeneic treatment, which means that the T cells actually come from a donor instead of the patient having their own treatment, which takes out the apheresis step and broadens the option of what people are calling an off-the-shelf type treatment, which is where the treatment is more readily available. But again, the studies are still ongoing to see how effective these are. In terms of the outcomes, many of the patients are coming off their treatment now. So we are paying very close attention to what happens as these patients stop their therapy and see how long they're able to stay off their therapy for. But this is not a treatment in which it is very easy. You come in and you just have an infusion, you go home. This needs very, very careful planning. It needs very careful communication between multiple different types of doctors, and the patient is monitored incredibly closely, particularly in the first week or two after treatment.
Yeah, incredible. And I suppose the risk is probably with the kind of deep immunosuppression, because you're lowering down the immune system before you take out the B cells, and then you take out the B cells, so you put the immune system even lower. So the risk of infection is, and I suppose when you mentioned the allogenic, which is kind of you have cells from someone else, right? So they probably do some kind of HLA testing beforehand,
Yeah.
but there is still
Yeah.
the risk of kind of graft rejection. I don't know how we would call it, syndrome, right?
the risks that come with the treatment, immunosuppression is one of the things that we can consider. And we think about that in all our patients with lupus, in particular those with very active lupus, where the immune system is not doing what we'd want it to be doing, i.e. protecting that person from infection. Add to that, people get immunosuppressive treatment, it lowers the immune system further. And so the question has been about CAR T-cell therapy, is this almost like a complete reset? Are you kind of wiping the slate clean and giving someone a new immune system, i.e. you've never been exposed to any pathogens before? And we don't think that's the case. In the studies so far, vaccine response has been preserved. So we know that patients are still able to mount a good vaccine response to vaccines they've had many, many years before, after they've had treatment with CAR T-cell therapy. We know that it wipes the B cell count very low, and that this can take approximately 100 to 120 days to return, which is something similar that we see in the blood of patients treated with rituximab. And albeit that there is an increased risk of infection seen there in patients who are otherwise well and typically quite young without any other major risks of infection, they tend to tolerate this quite well. The main side effects that people are interested in that are very specific to CAR T-cell therapy are what we call cytokine release syndrome, in which case the body starts to produce a number of inflammatory markers that can cause patients to become unwell in the short period after treatment, in which patients will often have a fever, and that can sometimes cause organ dysfunction, which is why patients are kept in hospital for 10 days. Now, again, the very early studies are telling us that this is not often seen in patients treated for lupus, and there's many reasons for this that we're often debating. The second is ICANS, which is an immune effector cell neurological toxicity, very much like CRS, but affecting the brain. And this can cause patients to have a low GCS, become confused, slightly delirious, and can result in patients having seizures. Again, this can occur within the short period after treatment and is why patients are monitored very, very closely. But again, in those patients treated for autoimmune conditions, this is seen incredibly rarely and is not being seen at the rates that are seen in patients undergoing treatment for blood cancers like lymphoma. Now, this again is all based on very, very early preliminary data, and I think safety is going to be the key thing that tells us the utility of the treatment in the future, because if we can demonstrate this is both safe and effective, then it's likely to develop much, much wider spread use. Whereas if the efficacy wears off over a period of time and actually we see a number of these safety side effects, then that will significantly hinder the widespread use of the drugs in the future.
How do you see innovations like Kuma Health contributing to the futures of lupus care, and why is it important for both patients and clinicians?
So I think one of the things that we really struggle with as clinicians looking after people with lupus and many other autoimmune conditions is that we only capture how that person is really feeling in the snapshot of what we're doing in clinical practice. So patients may spend 20 minutes or half an hour with me in which we have a number of things we'd like to discuss. Doctors like to discuss symptoms, blood tests, and medication, and patients will often have their own concerns and considerations that they would like to discuss as well. And half an hour is not a long time to do that kind of assessment, and I appreciate that in many other hospitals half an hour is a luxury, and many doctors and patients have much, much smaller appointment times. So I think the use of digital health and being able to communicate and identify patient symptoms remotely and virtually is hugely important. It can be important for agenda setting. So, for example, if I knew from a patient's app data that they had a particular symptom that they were suffering from, that we can talk about that in the clinic appointment and I can make sure that's addressed. Similarly, it's helpful for me to know whether the treatments I'm given are truly working. And I think that it's always very useful to have that data available to see how someone has done between appointments. If I was to think about the future and I could see patients in clinic, and in that clinic visit, I could see a whole dashboard of symptoms and how that patient is feeling, then it would give me a much, much better idea of whether treatments are working and how that patient's doing. Similarly, if I see that there are symptoms that are becoming more prevalent, more troublesome, then I know that's something that we need to address. So I think the use of digital technology allows us to have a much better view of the patient between clinic visits and gives us a much better understanding of how that person is living on a day-to-day basis with their condition.